Management of lower GI bleed. Establish 4XS, large bore, and start 4. Restore volume and replete red blood cell deficiencies. Lab CBC, electrolytes, coagulation profile, blood type and cross-match. All coagulopathies require reversal. Esophagogastroduodenoscopy. Inspects the esophagus, stomach and duodenum. Colonoscopy. Studies shows that colonoscopy can identify definitive bleeding sites in more than 70% patients with lower GI bleed. Capsule endoscopy. A small pill containing video camera transmit images of small intestine. Balloon-assisted enteroscopy. A wireless scope inspects part of small of intestine that EGD and colonoscopy cannot reach. Endoscopic ultrasound. An ultrasound probe attached to an endoscope shows all the layers of tissue of digestive tract. Cord enterography. Involves ingestion of a neutral contrast agent to distend the small bowel followed by cord imaging of abdomen. MR enterography. An alternative to cord enterography. It has advantage of not using ionizing radiation which allows for sequential images of small bowel. Nuclear GI bleed scan. Identify active hemorrhage. Angiography. Following is a flowchart showing how to manage a patient with lower GI bleed. First, check whether he is hemodynamically stable. If he is stable, then we will do colonoscopy to identify the source and treat the source of bleeding. If colonoscopy didn't identify the source, then next we do EGD as second line for identification of source of bleeding. Important note: if patient is hemodynamically stable and gives history of single episode of self-limited hematochezia and negative initial colonoscopy, can be observed closely without further testing. If patient is not stable, first resuscitate the patient and then do emergent EGD to identify the source and treat the source. If source is not identified by EGD, then we will do colonoscopy to identify the source and treat the source. In cases when both EGD and colonoscopy proved futile, then this case will be classified as obscure GI bleeding. Now we will decide whether to repeat EGD and colonoscopy, or keep patient under close observation, or do CT angiogram of abdomen or pelvis, or do push enteroscopy, or do tagged RBC scan, or do capsule endoscopy.